it's really a mistake to operate on an image. So we always talk about that, like you never want to operate on imaging findings. And I think that's really confusing for patients now, because now that we can all see all of our records and you can read all the MRI reports, it can be really scary because you read these MRI reports and you'll think that your whole spine is falling apart. You think you need surgery on your whole spine. But that's not the case. We want to operate on, in a way, you want to get the biggest bang for your buck, right? You want to operate on the segment that is going to help the patient's main complaint. That's why we do that. The other thing too is, the other reason that we don't, just operate on everything at once is because imaging findings don't necessarily mean pain. So, even though, like I've seen some patients of mine that are in their 90s, they have the worst looking spines you would ever seen. They've never had a day of back pain in their life, right? So just because something looks bad on imaging doesn't mean it needs to address surgically. And that's a super important thing that I really, would want my patients to know. The other question that we have to balance as surgeons operating on degenerative scoliotic spines, we're always trying to figure out, okay, it's not bad now, but is it gonna get bad in a year? Because we also don't want to do an operation on one part of the spine and then have the next adjacent segment become a problem in a year. Now, if it becomes a problem in 5 years, that's acceptable to a lot of people. But being back, in 6 months to a year, you want to try to avoid that. And we're still not good at predicting that. We just don't have enough research on it, and it's just so heterogeneous. Each patient is so different that trying to predict that is really tough. So yeah, we do try to balance that. We definitely try to balance, the things that look like they could become a problem relatively soon with the things that look like they may be a problem years down the line. But that's, and a lot of times that's the decision making that you got to make with the patient too. So a lot of times I try to give patients options and say, this could become a problem. I don't think so. I could be wrong. But trying to balance that is definitely where the decision making becomes tough. The other reason that treating the symptom is complicated is because imaging doesn't always translate to the symptom and vice versa, right? So a lot of times somebody may be having really bad leg pain and you don't see anything on the imaging that makes any sense to fit with that. So that doesn't mean you should do surgery in that instance either. So that's what I think makes spine surgery so interesting and complicated, is because the correlation between symptoms and imaging is not always one-to-one. It's super variable, and understanding that as a patient, I think, is really hard too. So when we think about surgery for adult degenerative scoliosis, the success of surgery is completely dependent on the symptom. So when patients are having primarily leg pain, when I can see lots of nerve compression on the MRI, I know that patient is probably going to do pretty well with surgery. The patient that has a lot of back pain, on the other hand, and if that's the primary reason for coming into surgery, that can be a little more nuanced, because back pain doesn't always respond super well to surgery. I think that's because, our solution for back pain right now is to fuse the spine, at least when it comes in the context of a degenerative scoliosis. And in the end, fusion is not a normal situation either. So it's like, we take one situation that is abnormal, we're replacing it with another abnormal situation. It's a better abnormal situation, but it's still not getting the person back to a normal spine. So that's why, surgery for the back pain component of adult degenerative scoliosis can be a little tougher to predict. The other symptom, if it's a postural problem, right? If the degenerative scoliosis is so bad that the patient is, leaning forward, they can't stand upright, or they're off to the side, that does tend to respond pretty well to surgery, because, it's a structural problem. We can fix the structural problem. But the thing about when you're changing someone's posture is that they really want to go back to that old way they were. So that's sort of the one. That's another. So that's a type of degenerative scoliosis problem that I do think responds very well to surgery, but it's also the kind of problem that tends to have the highest risk of needing more surgeries down the line. So.